I feel uncomfortable when insurance insists on patient getting a biosimilar medication. And we just started, and I'm sure in the future we'll have other biosimilar and other generic medication to be used in MS to reduce the cost. The question is, are they equally effective? And I think that's what we all struggle in clinical practice. And patients ask us many questions. Is this okay for me to go on this generic? What happened? What if I'm not doing well and such? And I think the fact that they are not clinical trial, but that's how generic are. They look at the biosimilar, they look at the structure. And again, I think that, for example, as I mentioned, glatiramer acetate is such a unique mechanism of action. It's really a very tricky things that look at sequencing of amino acid. And if you get a batch now and you get another batch in a month or 2 months, it might be a little different than the one you receive. So I think it's such a smart mechanism of action. How can you biosimilar such a thing? So that's number one. Number two, I think it's uncomfortable for me, for my college, to prescribe something that was not really involved in any clinical trial, didn't look at patients, wasn't tried in patients and shown to be effective in patients, either with MRI data. So one of the companies that have generic glatiramer really did some study with MRI, and I think that's okay, as long as they have some data to tell us that it can control the progression of MS. Again, it's a debilitating and disabling chronic illness, so you want to stop the progression, you want to minimize risk of relapses, you want to maintain good quality of life. And I think what's really important here, to show some data. It doesn't have to be 3,000 patients, doesn't have to be 2 phase 3 trials as we do with new medication, but it should have some clinical trial, and I think the FDA should come with that policy and say, for any generic and biosimilar, we need to have some kind of a pilot study or a mini study that showed the efficacy. And I think once that being done, a clinician will feel much more comfortable telling the patient, okay, you can go on a biosimilar and you can take this medication, you'll have the same effect, and we'll monitor you. That's what I do today. I'm monitoring these patients vigilantly just to make sure that they're doing well. And if there is any breakthrough, then at least that's allowed, and we do that very often. If they didn't tolerate the drug and if there is breakthrough disease, the insurance will allow the patients to go to the brand name medication. But I think it's a bit, I must admit, it's an uneasy situation when you know this combination, biosimilar medication, did not go through any clinical trial, and I'm just giving something based on some work in the lab. And that's it, in a lab that's different than the original lab that actually created this new molecule. So, and I think many clinicians feel that way, although we want to reduce the cost, and the National MS Society always speak about generic medication and biosimilar, and that's the way they say to reduce cost. I think the future will tell. Nowadays, I have quite a number of patients on biosimilar, so we'll see what happens in the future.